All right, we'll get started. We're going to do lecture 39 today, talking about some therapeutic procedures in the blood bank. For the most part, this will probably be a review. We're going to talk about the process of apheresis just a little bit more in detail. And this is the only lecture we have scheduled today, so we'll get started. All right, so we've talked about the apheresis process before. What does apheresis mean? Apheresis is the blood donor process where the desired product is kept and the remaining other components are given back to the patient. And so we've talked about you can do red cell apheresis, you can do platelet apheresis, plasma apheresis, and then those remaining components are given back to the patient. Just to let you guys know, if any of you have not seen the apheresis process or actually gone through the apheresis process, this is usually what the instrument looks like. There's a lot of tubing, and inside this instrument there is a centrifuge. So for instance, if you were donating plasma or platelets, it would be centrifuged. The desired product would be aspirated off, and then the remaining components would then be given back to the patient. Now there's, just so you guys know, that centrifuge that I mentioned that's built into that instrument, it will spin down your specimen. And so remember, your erythrocytes are gonna go to the bottom because they have the heavier mass. Then in your buffy coat, you will have your leukocytes and your platelets, and then your plasma will be spun out as well. Remember we talked about for those patients that are sickle cell or thalassemia and are transfusion dependent, and they receive a lot of transfusions, what clinicians have started doing is using neocytes to transfuse those patients, which allows those those patients that get transfusions very frequently, allows them to go longer periods of time, because using those neocytes can survive longer in their circulation. So it decreases the number of transfusions for those patients. And so neocytes can be harvested through the apheresis process as well. Sometimes if a donor is known that they're going to donate for neocytes, a stimulating factor might be given to them, such as erythropoietin, to stimulate release of new cells from the bone marrow. And also for granulocyte apheresis, I think we mentioned that as well, because there are so few circulating granulocytes. If you are trying to obtain a granulocyte for transfusion, stimulating factors might be given to that donor as well to increase the yield of granulocytes for that apheresis collection. And this just kind of demonstrates, I think I have a better picture. So here's your donor. So the products would come out and go into the instrument, can be separated out, and then the product that is desired is kept, and then the other products are given back to your patient, or back to the donor, I should say. So we first saw apheresis being used. Platelets was the most common component that was collected using the apheresis collection process. They're also doing therapeutic apheresis now, where maybe your patient has TTP, where they have that very large high molecular weight fibrinogen molecule. And so they pull the patient's plasma off and then give the patient donor plasma back. So that's being used too. Waldenstrom's macroglobulinemia is another condition because of those very large IgM molecules in the patient's circulation. They might decide to do a therapeutic plasmapheresis to remove those very large IgM, which could decrease the viscosity, decrease the stress on the heart. So that's another example where they might do a therapeutic plasmapheresis. There's two different types of apheresis process, and I think I've mentioned this before. You could have the intermittent flow, all right? That only involves one arm, so you only have one needle in a single arm, and they usually rotate. So they'll take some product off, spin it down, keep the desired product, and then using the same needle, the product will be given, the product that's not being kept, the remaining components are given back to the patient. Those instruments are usually smaller, and again, only one arm of the donor is being used. Now, continuous flow, and this would be very good if you're collecting maybe like a larger volume. Continuous flow uses both arms. And so as one arm, the blood is going to be pulled out into the instrument, centrifuged, the product that is desired is going to be kept, and the remaining products are given into the other arm. That is a continuous process. You don't have the intermittent stops and starts like you do with the intermittent flow, using only one vein, one donor arm. Filtration might also be used instead of centrifugation. The blood would pass over a membrane of the filter containing a specific pore size. So those cells that can't make it through the pore are trapped. So plasma would be a really good option here too, because it would make it through that filter, removing the cells and the platelets. And again, this might be a good option for those Waldenstrom patients where those very large IgM immunoglobulins, those proteins get trapped as well in those pores. Otherwise, another way to treat those multiple myeloma patients and Waldenstrom's is just to completely remove their plasma in their circulation and give them donor plasma. That would be a plasma exchange. They do those on some of those patients as well. So if you think about some of the advantages of apheresis collection, you are getting, think about platelets or granulocytes, you are getting a therapeutic dose from one single donor rather than having multiple donors pooled together. So that increases the likelihood of being able to get an HLA match, thus reducing febrile non-hemolytic transfusion reactions that is commonly caused by HLA antigens and antibodies. And therefore, too, if you have a patient that is become refractory to platelets, providing that HLA matched platelets could be a better outcome for them as well. And then again, you have one single donor, so you're reducing the exposure of your recipient to the number, to the risk of being alloimmunized from multiple donors. And then for the donor can donate more frequently too by plasmapheresis. Donor can donate every 48 hours, but not more than 24 times a year. So that's for your platelets. And for plasma, it's every 4 weeks. So typically in a normal apheresis collection, we are keeping the desired component. We are not, unless it's a therapeutic apheresis exchange, all right? So unless we're taking off their plasma because of a condition and replacing it, in a normal apheresis donor process, we are not replenishing that product. They are donating it. They go the designated amount of time so they can rebuild, replenish that product on their own. So we are not giving them any product to replace it. Again, unless it's a therapeutic condition. And so we've talked about this before, the platelet pheresis, again, very useful if your patient has become refractory, just due to those HLA or platelet antibodies. And remember the definition of refractory. So typically after a platelet transfusion, your patient's platelet count should jump up to between 5,000 to 10,000 microliters, and that's per unit. So a patient would be refractory if that platelet count does not increase as expected. Most all of your platelet products will be leukodepleted to get rid of those white cells, as well as all of our platelets will be irradiated as well, just because those platelet antigens and HLA antigens can occur on those platelets as well. So we will irradiate. And then if you guys haven't been in a blood bank and you're not familiar with what a platelet looks like, this is what it looks like. It's very similar in coloration to plasma. There is a small amount of plasma mixed in, remaining in the platelets as well. And remember, a platelet apheresis should be equal to about 6 single donor apheresis units. So this is equivalent to about 6 donor units, which is considered a therapeutic dose for platelets. And remember some of our donor requirements: no aspirin for 3 days, because aspirin will inactivate those platelets. So that's one of the questions before a patient can do platelet apheresis donation. We want to make sure they haven't had any aspirin or aspirin containing drugs within the past 3 days. And then your donor platelet count must be greater than 150,000 per microliter. So if your patient has a low platelet count, of course, we don't want to put them at risk for spontaneous bleeding by taking their platelets. So leukapheresis, and if you think about your leukocytes in your circulation, they have a very lower lifespan than our white cells and our platelets. All right, so they're not in our circulation for very long, and then your numbers seem to be a lot smaller as well. So one thing for granulocytes, there's a problem getting enough to be considered a therapeutic dose. So what happens is, usually on these patients, they can be given a hydroxyl starch, which is just a it kind of helps separate the red cells from the white cells, and it kind of enhances the ability for more granulocytes, more yield from that apheresis. Steroids have been shown to also be helpful. And if you think about from hematology, we talked about the 2 pools of white cells in our circulation. You have the circulating white cells, and then you also have those that are marginating. So sometimes steroids can help activate those marginating cells and help them release from the epithelial lining of the vessels. So then we can also collect them during the apheresis process as well, increasing the number of granulocytes obtained from that apheresis. And like I mentioned earlier, sometimes when collecting granulocytes, they will also give stimulating factors to help those white cells be released from the bone marrow. And again, that's only to increase the yield of the granulocytes from the apheresis process. All right, so think about this. We are wanting to obtain granulocytes, so it's very important that we do not leukodeplete or filter the granulocytes. All right, the granulocytes is what we want. However, we do want to irradiate the granulocytes, all right, to reduce graft versus host likelihood. And then we can obtain neocytes, like we mentioned earlier. Again, this is desirable for those thalassemia patients, and starting to even see this be incorporated for sickle cell patients as well. And that's just because these patients get so many transfusions. Number one, they're exposed to multiple donors. And then number 2, they will have iron overload, which is often treated by iron chelation. By using reticulocytes, those younger cells are able to survive in your patient's circulation longer, therefore decreasing the number of transfusions for these patients. So you might have heard this in the news. There is convalescent plasma that's being used to treat COVID-19 patients right now. So the plasmapheresis process is actually being used to collect those plasma from patients that have recovered from COVID-19. So they have the antibodies in their circulation. They can go and donate plasma. That plasma donation must go through all of the routine infectious disease testing. That is something the news is not reporting. So if you have been following that, they make it sound like you can just take plasma from one patient and give it directly to the other patient. I saw a diagram that had a needle in the patient's arm and then a needle in the other patient's arm. So it does have to go through all of the routine infectious disease testing. And this is for COVID-19. So if you guys are following it, some blood bank topics that are in the news right now. There are some donor requirements. So in order to be eligible, if you have recovered from COVID-19 and you are symptom-free for 28 days, then you are eligible to be a convalescent plasma for COVID-19 donor. However, if you are symptom-free for only 14 days and have 2 COVID-19 negative tests, you can also donate, and then they will titer that COVID-19 antibody, and that titer has to be greater than 1 to 60 is what the current data, current guidelines are suggesting. But keep in mind, this convalescent COVID-19 plasma is not FDA approved yet. So this is actually considered clinical trials. So the hospitals are having to apply for these clinical trials and be approved in order to treat their patients with this convalescent plasma. But it's the plasmapheresis process that these donors can collect. And they've used this for other disease treatments as well. If you guys remember Ebola, there were 2 nurses that became infected with Ebola. They had traveled to the Sierra Leone area, got infected, and then there was a doctor that had previously recovered. That doctor's plasma was used to treat those 2 nurses, and those nurses recovered from the Ebola. So that convalescent plasma is passive immunity. They have used it in the past as well. And so I was researching the COVID-19 plasma to determine what the therapeutic dose is. And so the FDA is recommending that 1 plasmapheresis collection, 1 unit should be enough if that titer is greater than 1 to 60. So that usually end up being like 200 mils. So 1 full unit is considered a dose. Now there's some conflicting data. I think in China, they were treating with 1 200 mil dose convalescent plasma. I did see one study that gave multiple doses, like 1 200 mil on one day, and then 1 to 2 days later gave another 200 mil dose. So there is that kind of research going on too about the dosage, the amount. But very interesting to see blood bank topics in the news, really highlighting the laboratory profession. So the main thing about apheresis, therapeutic apheresis, whether it be to treat Waldenstrom's, TTP, where you're removing the patient's plasma, it's very important that you understand that is not a cure for the disease. It just lessens the patient's symptoms. So for instance, those very large IgM molecules that we see in Waldenstrom's, that makes the blood very viscous, could cause organ failure for those patients. So again, it just lessens the patient's symptoms, kind of alleviates the pain for those patients. So that is a good option for those patients as well. And so the next couple slides just demonstrate some therapeutic cytopheresis and how it's used to treat. So cryoglobulinemia, such as Waldenstrom's, which causes hyperviscosity, TTP, these are all ones that I've already mentioned, cold agglutinin disease, drug overdose or poisoning. So if they wanted to reduce the amount of that drug that's in the patient's circulation, plasma pheresis would be indicated then. So here's some other indications for therapeutic apheresis. notice that TTP, that Adams 13, that very large von Willebrand's factor. That's what we talked about. Sickle cell. So a lot of times on these sickle cell patients, because they have that increased abnormal hemoglobin S, a lot of treatment options for them include a red cell exchange. So what they will do a cytopheresis. They will pull off the patient's red cells, give them back the plasma and platelets, and then they will transfuse donor red cells depending upon the patient's weight. And that's one way to replace the patient's abnormal hemoglobin S with normal donor adult hemoglobin. And so again, that will lessen their symptoms. Not a cure, it just lessens their symptoms, provides some relief for those patients. And again, when we do these plasma exchanges or red cell exchanges, it's dependent upon the patient's weight. So if you were ever in blood bank and you were involved in a plasma exchange, they will give you the patient's weight, and then you will be responsible for calculating the volume, or the clinicians might give you the volume. And it's usually quite a bit. It's usually about, I would say, anywhere from 700 to 1200 mils, because they're pretty much removing all of the patient's plasma and then replacing it with donor plasma. And typically these patients will have it done over a period of time, 10 to 14 days. Some might even come in on a monthly basis to have it done. A lot of those patients with TTP, this will be a repetitive occurrence for them. And then again, the ultimate goal, if you're thinking about plasma exchange, is to reduce the concentration of whatever is present in their plasma, whether it be the large IgM molecules, that atom TS molecule for TTP, whatever is causing a problem. This plasma exchange allows the removal of that substance and then replaces it with donor plasma. Sometimes there's other treatments as well. You could use a substance that will bind to those circulating substances in your patient's plasma, such as monoclonal antibodies, and then extract it out through the apheresis process. Again, what you're most commonly going to see is the plasmapheresis, the plasma exchange. They do this a lot. Cytopheresis, so if you think about taking off your red cells, again, they would do this for sickle cell patients, maybe if they're thinking about removing the platelets. For those patients that have essential thrombocythemia, where their platelet count is greater than 1 million, we would take that off. We could remove some of their platelets to reduce their risk for throwing clots. And then also you could do therapeutic granulocyte apheresis to remove some of their white cells if they have an increased white cell count, such as CML. Again, in these conditions, you're not replacing the products, all right? So we are alleviating their increased counts so they don't get any replacement products. So here's some example for cytopheresis. Now, the cytopheresis there is cells, so it's dependent. You could think about white cells, you could think about platelets, you could think about red cells. So it's dependent upon what cell line is affected. So cytopheresis is very generic. And so I mentioned red cell exchange earlier for sickle cell patients, and that is really just to lower the amount of hemoglobin S. So what happens in a red cell exchange is you pull off the patient's red cells. Those are kept during the apheresis process and discarded, and then the same amount, equal amount of donor red cells are given back to the patient. And again, that's just to remove that abnormal hemoglobin S, to alleviate some of the symptoms of these patients, improve their oxygen carrying capabilities, decrease some of their pain associated with these sickling cells. May be used, red cell exchange, to treat malaria infections. For those patients that have a very serious malaria infection, we could remove those infected red cells and give them normal donor cells. Again, those are, they would be very extreme. You would have to be a very severe malaria infection. So some side effects of the apheresis process, and we've talked about this before, the citrate that is used as an anticoagulant once the product is taken out of the patient, centrifuged, anticoagulant is added, and then it's given back to the patient. That citrate can bind to the calcium, so it can cause your patients to have a decreased calcium. One side effect or a symptom of the decreased calcium is tingling of the lips. And then the patient might complain of abdominal discomfort. So the main thing that they will do is a donor collection facility or the apheresis clinic will give oral Tums to replace the calcium as well that is being chelated by the citrate. You also want to think about the process at which the rate of blood is taken off your donor. You don't want to pull it off too fast and cause hypovolemia. And so that could cause your donor to have an increased heart rate. So you want the flow of your apheresis to be appropriate too. And then just like a normal donor, the vasovagal symptoms might appear, the lightheadedness, the nausea, the bradycardia. Those are normal vasovagal. And the apheresis process, especially if it's a continuous flow, vein access. So we want to make sure our donors have easy vein access, because if you're doing the continuous flow, it does require 2 veins. So usually both arms are involved. And that needle is 16 gauge, so it is fairly large in size. And therapeutic phlebotomy. So if you guys remember from hematology, we talked about polycythemia vera, where the patients create too many red cells. So they have a very high red cell count. One of the treatment options for those patients is to have a therapeutic phlebotomy. And this is just really like donating a unit of blood. The patients will come in, have a unit of blood drawn off, and then that's it. And that unit of blood is discarded. It's not like a regular donor facility. So we actually used to do therapeutic phlebotomies when I worked at Baptist here in Little Rock. And so a lot of times if you are trained in blood bank and your facility does therapeutic phlebotomies, you might be involved in that process. Again, it's not a unit for donation. The unit, they just usually take off about 500 mils and then it's discarded. And so that just it lowers your patient's red cell count, and it leaves some of the circulatory overload for these patients. It decreases their red cell count. So we're starting to also see apheresis process be used to treat some hypocholesterolemia. So for those patients that it's a genetic condition, they have a increased cholesterol. One apheresis is being used to remove off that cholesterol to lessen the patient's cholesterol, help again alleviate their symptoms. It's not a cure, it just alleviates their symptoms. There's another one. They can take off the patient's granulocytes and do a photo treatment to try to kill or zap those malignant T cells. And then the other remaining granulocytes are given back to the patient. That's a fairly new treatment. So in that photopheresis, the drug is administered, taken up by the DNA of the white cells, the buffy coat. So that's the only thing that we're taking during the apheresis. And then the cells are exposed to the UV light, activates the drug, cross-links the DNA, damages the cells, preventing replication. So this has been shown to be beneficial in T-cell lymphoma, such as Sézary cell as well. I mean, like we talked about, you can use apheresis to remove immunoglobulins, such as Waldenstrom's or multiple myeloma. You can also use it to augment a patient's immune system following a allo bone marrow transplant. You can treat ITP when the patient has an antibody against the platelets, so try to remove that antibody by taking out the patient's plasma. And this is actually very interesting too. So we can do the apheresis technique to collect peripheral stem cells. This actually involves the donors having some type of stimulating factor to promote the collection of these stem cells. And here at UAMS, they actually do this. They'll do autologous stem cell collections. They'll harvest the stem cells, and then they'll freeze them. The patient will then undergo their treatment, chemotherapy, irradiation, and then following that treatment, they will be transfused back those stem cells. And that's just what I mentioned, those cytokines to stimulate the release of those stem cells, because we're collecting these stem cells from the peripheral blood circulation through apheresis. And like I mentioned, they'll be frozen. So usually what happens when those stem cells are transfused back, they will help stimulate normal cell growth in the bone marrow. So that's the idea behind these autologous bone marrow transplants or stem cell harvesting. So the peripheral stem cell collection has been shown to show success in some of our leukemias, such as AML, CML, and even for lymphomas as well. You might even see that being done for solid tumors as well, such as breast cancer. All right, so I know we already talked about the apheresis process, but this lecture kind of describes that process a little bit further, whether you're using the intermittent flow or continuous flow. And we talked about several different conditions where apheresis might be warranted. And remember, in the apheresis process, if it's a regular donation, then only the desired component is kept, and the patient does not receive any replacement components. However, if it's for a therapeutic treatment option, then the product is removed, and then the patient gets donor product back. So for Waldenstrom's TTP that we talked about, if it's a red cell exchange for sickle cell, those will, if it's a therapeutic apheresis, then those patients will receive products back. Depending upon the weight will determine how much. All right, so that was a fairly short lecture, and that's all we had scheduled for today. Does anybody have any questions? All right, so looking at the schedule, I will see you guys next Monday. And don't forget lab activities 12 and 13 are due today as well. All right, so you guys stay safe, practice social distancing, and I will see you on Monday.